Jan McGregor. Known Jan for a really long time, and she was been giving educational programs in geriatric medicine for quite a while. This is her bio, and I know she's gone to private practice. She's very much missed here, and I was really thrilled that we were able to contact her and hear about her expertise in driving on old age. So looking at driving retirement, the primary caregiver's role.
Thanks, Tony. If Tony had asked me to give this talk 10, 15 years ago, I gave a ground rounds about that much time ago, about the driving task, and I would not have been able to stand here and give you a very practical approach. I gave all this wonderful research, but I actually had nothing practical to tell you to carry home to your clinic, wherever you were seeing patients. However, it's different now, and I was very excited as I was preparing, because there's a lot that we can do now. So we already know this because a car is an extension of our very personality. The car makers love us because of this, and they've taught us well. We're going to learn to see driving risk factors like we see coronary disease risk factors. We modify risk factors in order to bring about a good outcome, and that's what we're going to be doing with the driving task. How do we modify the risk factors? There's actually ways to do that. And if they must retire from driving, notice the term retire from driving. It's newspeak, right? But it's another way of kind of showing that there are some good aspects too. If they must retire from driving, how do we convey that information and put supports in place until they've made this transition adequately? All right, no surprise, driving's important. In some of the suburbs of Houston area, even there's no public transportation, our social, recreational, it's all dependent on that. Next slide. All right, here we go. So we start at 38 on the clip, so you just click on it. Let's watch this video.
My name is Milton Cavalli. Next month I'll be 97. I've been driving for about 89 years. I think I'm beginning to learn how to do it now.
This is my grandfather. I've been a passenger in his car since I was a kid, so it never occurred to me there was something strange about him driving until he went to renew his license last year. The new one expires on his 100th birthday.
But I feel some people that ride with me figure, due to my age, they're a little bit apprehensive about my driving. They keep directing me which way to go, this way, that way, turn here, look out for that light there. I know all these things. I'm driving, I see them. Nobody has to tell me about them. When they do that, I figure I can't figure out there's a stop line ahead of me or something, you know. And that comes to be, I'm not driving anymore.
I'm Herbert Bauer, and I'm still 99, but not much longer. I have driven a car for about 80 years, and it's about time to change before somebody invites me to change. I have been driving without any accident for so long, and I wouldn't want to spoil my record. So I'll try something else for a while.
Will you miss your car?
I plan to. Yes.
Herbert and my grandfather are among the oldest drivers on the road, but they're not alone. Today there are 3 million drivers over 85, and as the population ages, their ranks are growing.
There's this myth that senior drivers are the worst drivers. That's a myth. It's not true, and statistics clearly show that the age group that we should be more concerned with is the youth group.
Older people are more likely to cause an accident than other adult drivers. But young people, under 25, are by far the riskiest drivers on the road. Teenagers are also more likely to kill other people when they crash. But older drivers, with their fragile bodies, are mostly a danger to themselves.
How can we distinguish the Milton Cavallis from the Herbert Bauers? You saw a distinct difference in their driving and in how they get around. How do we modify the risk factors for the Herbert Bauers so that maybe they can drive like the Milton Cavallis of the world? Okay. And finally, how do we tell the Herbert Bauers that after 99 years, large part of that driving, that they can no longer, we can't modify those risk factors for them anymore and they need to discontinue their driving? Okay. All right, whoa. All right, so what was the gentleman in this clip referring to? Well, basically, look at this is crashes. This is just raw data. If you look at, this is what the Department of Public Safety in Texas should be looking at, and this is what they do look at, that the crashes for older adults are the lowest compared to our younger counterparts. And the next slide, though, so from a public policy making issue, this is the slide of importance because we don't want to penalize the vast majority of very good drivers. However, the next slide shows that from a primary care standpoint, this is what we care about because this is the mileage adjusted crash risk. So at the age of about 70, when we look at the individual sitting before us, that individual, for every mile they drive, has a much higher risk of crashing. So you see, from a primary care standpoint, this is important to us, but not from a public policy making standpoint. And you will find people skewing these two, and it's very important that they do not. All right, so let's go on. We're obviously not public policy. We're right now, well, some of you may be, but right now we're going to go into our clinics. So on the average, we outlive our ability to drive. This is going to be an issue. Probably everyone in this room has dealt with it either in their family or in their clinic. 7 years, we outlive our ability to drive. All right? All right. In Texas, and every state's different. You really have to know your own state laws. In Texas, you know that you renew your license every 6 years, but you appear in person only every other time. So every 12 years you appear in person. And you have to do that until you reach the age of 79 years. And at that point, you renew in person every 6 years. That's not too bad. At 85, you renew in person every 2 years. And that's actually a change that's occurred in the last 10 years. So starting to recognize that after 85, the changes occur. But again, it's not too intrusive on someone's life. Next slide. All right. It is an important IADL, and Andrea mentioned it. Don't miss the opportunity in your clinic visit to address this issue. Think about it. So if we'll click on that.
Thanks for seeing me today, Doctor. Now if I can only find my car in that parking lot.
Parking can be tricky around here. How's your driving? Have you had any problems lately?
No. Well, I don't see as well as I used to. Sometimes when I'm driving, cars just seem to come out of nowhere at me.
All right, I will be talking about red flags. These are the things that should focus your attention that you find in the history to doing a focused physical exam. Next slide. Our red flags are anything that affects cognition, motor ability, or vision. And I could have made this list as long as this room. You know that. Because all these things affect one of these three or all. Notice at the bottom, though, daytime somnolence, OSA is obstructive sleep apnea. It's kind of become more of a prevalent diagnosis. And those people can fall asleep behind the wheel. And of course, drug-induced is very important. All right? All right. In our review of systems, same thing, same idea. Only added to that is some fatigue and weakness, because if you fatigue, then your concentration in the driving task, as you know, anybody's made a trip to 2 hours up the road, 3 or more, you fatigue a little, and you're not as attentive. Respiratory, so these other things are kind of clues that help you to realize that maybe this person's having a little bit of difficulty. So any disease that affects this, you should be thinking, IADL, driving task, okay? Anti-anything drug, right? That's easy to remember. You're on an anti-something, pay attention. Interestingly, benzodiazepines are no surprise, but interesting, non-steroidal anti-inflammatories can be the straw breaking that camel's back, because they do affect cognition, but very minor. But if a person is barely making it, that might be an important thing. Now, if your patient would like and is computer savvy, they can go online to Roadwise, if you click on that, and plug in their medication list. And this nice website shows them, so what they do is they would type in their medication name, and then they hit, boom, view results. Put in Xanax. Can you? Xanax. There it is, and actually has a pop-up. There you go, yeah. All right, and then there it is, view results. And interactions, food interactions, look there, driver warnings, 4 of them. Well, that's no surprise. We know Xanax affects the driving task. And if you continue to scroll, it should, yeah, you go. Well, where'd they go? There it is. Oh, you have to click on 4. There it is, yeah. And there it is. So trouble staying at work. So it gives the 4 different things to make the patient a little bit more aware of the fact that this is an important medication. It also includes interactions and whatnot. Thanks very much, Tony. Yes, next one, thank you. All right. So when we do our social history, health risk assessment, somewhere between asking about smoking, alcohol, and carbon monoxide detectors and our other usual ADL, IADL list, we need to ask about driving. And just as the physician was very subtle in asking, we need to be somewhat skilled in this. Did you drive yourself here? That's a nice way to say it. What kind of car do you? You got a truck? That's neat. How do you get up there? Oh, that's high. You can bring about a conversational tone. Are you having any problems operating your vehicle? And what about others? Have they expressed concern about your driving? Okay. Also, don't forget to address what other transportation would you use if you couldn't use your car anymore. All right. The American Medical Association and the National Traffic Safety Association, there's another letter in there, got together and put together all the research. And they came up with this focused physical exam, basically. They call it the ADRESS system, ADRES, which is basically assessing driving-related skills. And they go after vision, motor, and cognition. Okay, go ahead. All right, this is a terrible site. I want you to pull out your handout. This was just to remind me it's time for your handout. On your handout, you have the ADRESS score sheet. You don't have to use something like this. In fact, if you've done a very good initial evaluation on your patient recently, you've probably already addressed a number of these things. And I know in my clinic setting, all my patients are seeing ophthalmology at least once per year. So I already had visual fields and acuity by Snellen. I don't have to just rely on a Snellen chart. But there's some other interesting things on there. If you notice, below the vision is a rapid pace walk. Now you would say, okay, what has walking got to do with the driving task? But surprisingly, it does correlate with crash risk. So you mark out a 10-foot strip in a hallway in your clinic and ask them, they can use their assistive device just to walk there and back. If they can do it in less than 10 seconds, that's great. Greater than 10 seconds, that's a red flag for driving. Following that is a motor exam. It kind of looks long here, but if you think about it, when you're driving, what do you have to be able to do, right? This. You have to be able to get your hands up on the wheel. So you have to have strength this way and forward. Okay, that's pretty easy. What about your legs? Well, you got to be able to flex your hip because you've got to be able to move from accelerator to brake. And you have to be able to push down. So you have to have range of motion and strength in your ankles and in your hips and knees, actually, too. So that's pretty straightforward. On the second page, that would be the next slide. On the next page, gets to something that just excited the devil out of me, because when I was looking through the research 10, 15 years ago, trail making Part B is part of a neuropsychiatric testing for dementia. It's actually fascinating to look at. If you'll turn to the next page, this is how you do trail making B. Trail making B has you start at number 1 and connect not to number 2 but to A. And then from A you go to number 2. And then from 2 you go to B, etc. The patient should practice a little bit ahead of time, have them connect all the 1s first, and then connect all the A's and B's, and then say, okay, now I want you to alternate 1A, 2B. And they should be able to do it in less than 3 minutes, 180 seconds. And you might want to practice yourself to see. Anyway, the trail making Part B has, from the beginning, when I first started looking at this literature, correlated with crash risk. It was fascinating, but nobody was able to say, okay, you can't put it in the DPS office because, you know, you really kind of have to. I mean, the people who do neuropsych testing are PhDs and they're trained professionals. So how do you put that in the hands of somebody who's doing secretarial skills? So this is why the physician's office or primary care office is very important. We can do this. We can have someone administer this and get really good at it to help us out and score it. And then the next one, again, is wonderful. You take and you have them flip over their sheet and ask them to draw you a clock, the clock draw test. You should be familiar with that. You draw a clock, it should be a round face. The numbers should be equally spaced and inside the clock. And you ask your patient to, just leave it right there. You ask your patient to put in the time of 11:10. Or you can pick a different time if you want, but don't put it on the quarter hours. Make it a little bit more challenging. They give you a great scoring system here, yes, no. It's very straightforward. And if you have a problem in any area of this, then that's a red flag. This is a normal clock draw test. Notice the symmetry, the hands showing 11:10. They don't have to be able to distinguish shorthand or longhand, just 2 hands. Now the next one, this is an actual abnormal one. This person obviously has a military background, but you'll notice their clock draw test has changed drastically. They have 24 hours on there. They still have 2 hands, but again, this is abnormal. Next one. And here we have another one, military time, but it's not completely accurate like the other one in that regard. And look at all the hands on the clock. Looks like the spokes of a wheel. I have seen clock draw tests. Oh, Dr. Raji could probably give us some great examples. Clock draw tests where you have all the numbers crowded onto one side. I'm sure you've seen them. It's a fascinating test. Getting at visual spatial skills and those sorts of things. And of course that's extremely important in the driving task. So clock draw test and abnormality, that's a red flag to look for dementia. And that's pretty much it. Now read this. It makes a loud grinding sound whenever I merge onto the highway. My hope is that our patients' auto mechanics aren't making the diagnosis of driving impairment. Okay, next one. So here we go. This is getting to the crux of my talk. I wanted to, what do we do if they refuse the evaluation? They refuse for us to assess their risk factors. Well, I'm here to tell you that you've pretty much already assessed the risk factors. All I've done is put them together so that you know what actually correlates with crash risk. Your task is easy. The road-wise we looked at, that's you can tell your patient, if they're computer savvy, go in and put your medications in. This is why I'm concerned. You do this on your own. Am I a safe driver? That's on the second page of your handout. Am I a safe driver? I get lost while driving. My friends or family members say they are worried about my driving. You don't have to have them sit there and fill it out. Just send it home with them. If they have insight and judgment, they will look at this and they'll say, oh, okay. Stress to them that you are not taking away their driver's license. You do not have that authority. It has not been vested in us. Thank you. And you're here to support their effort to drive and to modify risk factors just as you would for coronary artery disease or any other illness. You would look at the driving task in order to support them. All right. You're assuring their well-being and the well-being of the public at large. This is in your handout. Am I a safe driver? Okay, next slide. All right. So at this point, what if the patient has continued to refuse. And this is a clip that shows that same physician that was sliding into asking the woman about the driving test. He is, or driving task, excuse me. He, in this one, is talking to a man who he has tried to do an evaluation on. The man refused, was very upset by it. And so now he sent him home with the things I just told you about.
I had another near miss, and this time, yeah, well, it was partially my fault.
I've ridden with Dad a few times, and I've noticed a number of things about his driving that really have me concerned. He has some trouble staying in his lane and sometimes drives too slowly for traffic. I noticed he also isn't checking for other cars as frequently as he used to.
My daughter made me more aware of some of the errors and mistakes I've been making, and so I decided to try your Am I a Safe Driver worksheet.
Okay, how did that go?
It was kind of an eye-opener. I guess I should go see that driving specialist you were telling me about last time.
He did develop some insight through the tools that he was given, and notice that that physician has also counseled the daughter who has come with him. She was very specific about what she noticed that bothered her. There's no emotional overlay on that, it's just this part bothered me, and he can understand that. Okay, so this physician has access to an occupational therapist who's trained in driver rehab. They're called driving rehabilitation specialists, and they can actually become certified in this, and there's a national agency that they are registered with. They develop and coordinate services for individuals with disabilities, and they're typically OTs. And refresh me, are we still, and we have still drivers training? Is there any PTOTs here? I think it was in PT here at UTMB, the driver simulation. I don't know if Ike took it away or not. Anyway, we did have it at UTMB, but we were not listed in the directory. So next slide. Okay, so if you click on that, there is a, since we're all over the place, not just in this room, but in other places, if you wish to find out if there is one near you, you can. Not a lot. All right, but what about the cost? Well, to get an initial assessment, you're looking at about $300 to $400, and if they want, if they require training rehab, either behind the wheel or with a simulator, you're looking at about $100 an hour. So this isn't available to everybody, but it is something to think about if your patient has the means and there's someone in your area. Right. What would they do? Well, you can do car adaptations. You can, in patients who lose height due to osteoporosis and fractures, they're starting to have trouble seeing over the steering wheel. Well, you can get them up. Well, if you get them up, then what's that do to their ability to reach the pedals, right? So what you do is you bring the pedals to them. You can put in extenders and whatnot. Next slide. Here, the person, this car has been adapted so that, all right, so here, this has been disabled. The person is unable to accelerate with their right foot, and they're being taught, this is the accelerator now, and here's the brake. So this person was learning, the person who would operate this car would be learning to drive with their left foot. Okay. And then here's a further modification on this, the shift, where it's closer, it's connected here and closer to the steering wheel. This used to be what all cars look like, and now it's kind of much more cooler to put it right here, right? I don't know what Buicks and Cadillacs look like. They get over here. But again, this is this strength. So this is an adaptation for where your patient does have the ability. All right. All right. Alternatives are very important because you saw how important the driving task is to all of us. So walking, public transportation, friends, family, paratransit, community transportation services. This is just a laundry list. Go ahead, Tony, just keep hitting them. Medicar. Delivered services, maybe some meals can be delivered to the home, then Meals on Wheels. Volunteers, keep going. All right. For-profit elderly care services. I think this was Northeast. I saw some clips about professional services where they only drive folks who are over 65. Okay? And this, yeah, I bet y'all are familiar with this one. Elder Care Locator. This should be in your handout, this website. So you can search by location. It'll basically take you to the central clearinghouse that's dealing with the county dollars that pay for elder care services. So you can put in the town you're in and find out what's available. Your money, though, is your social worker, because that person already knows all these things, and you don't have to rediscover any wheels. So the other person who might notice you're driving is your dog. This is my favorite slide. All right, next slide. All right, so despite your best efforts, the patient can't drive anymore. If you've been doing this from the beginning, which from this day onward you will, because now you know, okay, I know what things count, then they're involved in the process with you. The AARP has community organizers who give defensive driving courses for free for elders. You can help them find that. Your social worker might know that. You've developed a trust and a rapport, hopefully. Hopefully it's not your first visit and there's that daughter, you've got to make them stop driving. And then you're in trouble. That's going to be difficult. Along the way, you've been counseling them. You need to find alternative transportation, start talking to people, find out about carpools, what you can do, recruit a family member or a friend to help. Okay? And make sure that when you follow up, you do make sure they're in compliance with what you've recommended. If you've recommended they stop driving, make sure you're screening for depression and social isolation. Again, very important. We don't want this to happen if we can avoid it. Okay? All right, so this is a clip, same gentleman that you last saw, and this is emphasizing the skill that basically do not back down. If you have found multiple red flags and you cannot modify them, and you feel they're an unsafe driver, you don't have a rehab specialist, you don't have any way to further help them, then you're going to have to be firm and say, I really feel at this time you need to stop driving and stick to your guns. Okay.
Mr. Phillips, your road test did not go well. We discussed during your last visit that there may come a time when you need to stop driving. That time is now. You need to stop driving.
Well, I can't just stop. I need to drive.
Again, Mr. Phillips, these results have me very concerned. I realize that this is difficult for you to hear, but my recommendation is for your own safety as well as the safety of others.
In Texas, we do not have a law that says we have to report them. I read a study where in a particular area in Canada where the physicians were paid to report their patients to the DMV, the Department of Motor Vehicles. I really didn't like that. And yeah, they reported, oh, there was a great report rate. And yeah, they reduced crashes, oh yeah. But their physician visits fell off by 25%. That's not what we're looking at. We want to be supportive. It is our ethical responsibility, though, to address the issue. And when we've exhausted everything, to recommend that they restrict or cease driving. And we really are influential. In fact, that's the advice from a physician is the most frequently cited reason that a patient stops driving, surprisingly, because they don't do anything else. You still smoking? Oh, yeah. But believe it or not, it does have an effect. Okay? All right, so let's explain why. Again, just as the daughter was very specific, I've noticed that he's not looking both ways. We are very specific. We did the focused physical. This is what I found. On your test, you didn't do very well, so explain that result to them and how it affects their driving task. Tell them about the risks to themselves, but mostly, what about the children out there? Because that's what we all care about children. And so would you want to hit a school bus or a child hopping off a school bus because you didn't see them? Liability, family member. Try to recruit a family member to come. Have the patient early on, before you get to this point, designate a family member they wouldn't mind telling them when it's time to stop driving. Identify that person, chart it. All right, again, we can refer to social workers, great idea, and document. Okay. All right, you must expect anger and denial. We've been walking eggshells on this issue for so many years. We don't have to walk eggshells anymore because we have something that is legitimate science that says, okay, this is real. So, but expect anger and denial. Ask the patient to tell you, okay, why am I asking you to stop driving? I don't know. No, really, specifically. What have we just talked about? Stress, safety again. Write on a prescription pad, do not drive. Hand it to the patient and hand one to the caregiver if you were managing to get a caregiver in there. This is especially useful in dementia. Dementia is a whole nother can of worms. We'll talk a bit more about that. So let's look at, this is a video clip from the Alzheimer's Association website. And this is a layperson talking to her husband, but this is the influence of the prescription for her. Okay.
Frank was diagnosed last year with Alzheimer's. His doctor has insisted that he stop driving immediately due to his diminished and deteriorating cognitive judgment. Frank's wife, Betty, agrees with the doctor. However, Betty has never driven and is an unlikely candidate for learning. She has relied on Frank for all of their transportation needs, but she knows she must confront him.
I think I'll head on over to Jim's before it gets too late.
Oh, honey, wait a moment, please. This is from Dr. Robinson. Do you remember from yesterday?
No, I do not.
Would you read it, please?
There's nothing wrong with my driving.
You almost hit a man yesterday. He was on his bicycle, don't you remember?
There's no such thing as a prescription to stop driving.
This is from Dr. Robinson, just to remind you, when we met with him yesterday. We met yesterday morning. Honey.
I know, Okay. I sometimes forget where you get your hair done. On Fridays, where you get it done on Fridays, but that has nothing to do with my driving.
You always told me to be honest with you. When this thing first started, you said no matter how difficult, I needed to be direct. You almost hit a man yesterday. He was riding on his bicycle. Do you know we could never live with ourselves if we hurt someone?
We?
This is us. We're a team. This is us, we. Frank, you've been driving for almost 60 years, and you're a great driver. But things change. We're older now.
You could drive us.
Not with my eyes. I couldn't get a license.
The cinnamon rolls. The coffee and the cinnamon rolls at the mall. Who's going to drive us there in the morning? That's our group.
Frank, I've been thinking about this. Ted and Joan always say they want to help.
He's a terrible driver.
Well, we could start a carpool and we'd buy the cinnamon rolls and the coffee. Huh? Just the coffee. Oh.
So she had all her ducks in a row. Wouldn't mind having her in my clinic helping me. She had all her ducks in a row. She had thought of alternative transportation and had actually talked to the people. Again, our role, we helped, her physician helped her because that prescription pad was a bone of contention. He couldn't get around that. Even though he didn't remember seeing the doctor, she had it there in hand, and he trusted her and was willing to listen to her. Another idea is to send your patient a follow-up letter and then make sure you see them again in about a month after you've made the recommendations so you can assess, again, depression, social isolation, make sure that alternative transportations are being explored. Okay? All right. At the follow-up appointment, make sure that they're complying. By the way, how did you get here today? Let them tell you what transportation alternatives they've identified, and again, look for isolation and depression. Okay. If they are belligerent, angry still, refusing to comply, still, you notice I haven't said, oh, call the cops. No. It's important for us to understand why. Listen to them. Is it pride? Is it practical? On and on and on. They have their reasons. And you may or may not be able to find a stopgap for that, but it's worthwhile listening so you at least understand why. Okay? Supportive statements, we already know all this. Let them know you're there to advocate for their health and safety, and always keeping in mind that this has severe ramifications for them. All right. Another thing to do would be to ask the patient, when do you think a person is unfit to drive? When you take this out and put it into a separate arena, like identify, is there anyone you're afraid to drive with? Now it's a safe conversation because you're not talking about them anymore. You and the patient are talking about somebody else. Oh, really? What was it about their driving that really frightened you? You know, that sort of thing. All right. This also helps the patient to develop some insight, and it helps you decide if their judgment is there and if they have any insight. If dementia is an issue, they may not. All right. Again, asking them to tell you what sort of support systems have they identified, or if they're very demented, the caregiver who's with them. Next. Be alert for depression. Help them see the positives of retiring from driving. They are asserting control over this situation by making decisions. They've lowered their costs of living, and let's face it, gas prices are not too cool. So, all right. All right. Inform them that non-compliance means you are ethically, not by law, you are ethically required to report them to the medical advisory board. You're only going to give the information pertinent to driving. You know that now. You've got it all. It's right there before you. You will send the medical advisory board will send you and the patient a letter asking for information and may request additional testing. They may even do a behind-the-wheel test if there's any question, which is nice. That means that even though we couldn't afford an OT to assess them, the Department of Public Safety, your tax dollars at work, will do that for you. Remember, anyone can report, and your identity is initially protected, but you are your patient's advocate. And I would never advocate doing that on the sly. I would say, tell them you're going to do it because they're going to suspect you anyway, and you might as well come clean. Remember, too, that you're not completely anonymous. And if it goes to court and they sue, you obviously they would know your identity. So it's not truly anonymous. Next slide. So the Medical Advisory Board advises the DPS on individual drivers. It bases its actions on the recommendations of the physician, their physician, who reviews a case. All you would do is provide information. The patient provides information. They can also ask information from other medical advisory boards in other states if that's an issue, and family members. They can access all of that. At the very end, there's a sheet for reporting if you wish. But all you have to do is send them a letter. So all you got to have is the address, really. That's the important thing. And it's done. So there's no official long form like California has. There's just straightforward, I have issues, and I think this patient needs to be evaluated. Okay? So, okay. So anybody can report. It's the release of information is an exception to the patient-physician privilege. You are protected. There's no reporting form, and it's not truly anonymous. I covered those. Okay. What happens next? The driver is notified in writing of the referral, and they're asked to bring a form to you to provide information. The medical advisory board will accept information from others, as I mentioned, and you, as a provider, are legally protected from the disclosure, for disclosing the information. Okay. This is some resources that we went over, AARP, the Hartford, and Alzheimer's, great websites. They have video clips and they have written information. Again, if you have a social worker who accesses this, they can sit in their office, hopefully, and look at some of this. Better yet, if they have a computer at home. All right? So, we should address the risk factors that relate to driving. Now you know some of them. I'm sure there will be more down the road, but at least we have something now to go on. We should focus on maintaining safe driving. So start early, because then the patient gets the idea that you are helping them to continue to drive, and that's your goal. Refer them, if you can, to a rehab specialist, or even a driver's education. They'll also do behind the wheel evaluations for you. if driving retirement is necessary, compassion of communication is very important. And then the very last resort is the MAB, the Medical Advisory Board referral, and try not to do it anonymously. I think that you'd feel better and your patient will know that you really did care enough that you went all the way. Okay? All right. Any questions?
Oh, okay. I just had a question on this is awesome material. I want to thank you very much.
You're welcome.
A lot of us are, me in particular, I deal a lot with the families on their side of it. So when you get to the point where someone's demented and it's causing a lot of problems, how do you help the family to put in safety protocols on their end to help minimize the person driving? What have you done?
There are many tricks, if you will. Dementia is very challenging when the patient, because at some point they no longer have the insight, as you've recognized. A lot of people just hide the keys. You can disable the motor. You can put in kill switches. It's a safety feature actually in some of our newer cars. If you don't have the right key with the little gizmo in it, you know, $80 to copy one of those suckers, the engine will just die. It'll start initially and then it'll just die. And they are demented, so you can say, oh, the car's got out again. Darn.
So it's called a kill switch?
Yeah, kill switch, might have other names as well. But yeah, there's definitely ways to disable the car. But again, the kill switch is nice because only one kind of key will allow the engine to continue to run, and so you can continue to use your car. If you unhook the spark plugs, you're in trouble. You know, and I wouldn't know how to unhook the spark plug. It bit me on the tail. Probably don't even have spark plugs anymore. Right? So good question. Yes, that's one way to help families if they really are at their wits' end, and you have a very strong-willed individual, and there's plenty of them out there. So yeah. Anyone else?
Thank you.
Yeah.
Any questions? Any other remote slide questions? Anybody from here? I was wondering, you know, it probably dementia doesn't matter, but you know, auto insurance can get, you know, pretty much out of hand. Do they, you know, is it more likely that they would have it's such an increased cost that it's just not feasible, and how much would that, you know, impact whether or not they were driving it? I mean, I doubt it would be that much, but I was curious about insurance.
Your point, it comes back to public policy. Insurance companies should make a policy based on the fact that this is the lowest risk driver of all of them. And indeed, their rates reflect that. You remember when you were 16, your parents were going, you know, strangling from the rates. But when you hit 25, their rate went, or your rate at that point, hopefully, went down. And so, and that just reflects the fact that you've been on the road long enough that you're a decent driver, you're a safer driver. The risk per person follows that curve per miles driven, but that's on an individual basis. That's the problem. So how can an insurance company do that? What they do though is if you have multiple accidents in a year, your rate goes up. So already they're doing it because they're not allowed to discriminate based on age. And indeed, given the raw data, they better not, right? So that's a great question. So actually, if they're a safe driver, their rate will be the same as it's always been, given inflation, a little bit higher. But then once they start having fender benders and report those, then obviously their rate will go up. And they can also report to the Medical Advisory Board. You know, there's nothing that says the insurance agent can't report.
One thing in people who are maybe mild cognitive impairment, haven't really crossed over into dementia, or the dementia is causing significant difficulties. GPS, to think about using the GPS technology so that if someone doesn't show up at the appointed time, wherever they're headed, that you can at least find where they are using the GPS.
Right, exactly. Great comment. For that use, it's absolutely valuable, and there are some great technologies to help us. However, GPS, even in younger individuals, is a distraction and actually makes the driving task more difficult. And in an older individual who's never had a GPS, they're really distracted.
It's not so much using the direction thing that gets you there. It's just on the vehicle.
Right, I agree with you.
When it
absolutely.
signals,
yes.
it pops down onto.
Exactly, exactly. And if the individual is getting lost, then that's a really big red flag that at some point very soon they're not going to be able to maintain their driving test. Yeah. But yes, GPSs, cell phones,
Right.
chips.
I have one other question. Do many clinics, I know they maybe have driving simulators, like maybe for looking at reaction times from brake to accelerator?
Some motor vehicle, the Department of Public Safety, they call them different things in different states, do that. I think Maryland has the most extensive testing of their seniors at the DPS office, and they do a reaction time, but simple reaction time isn't the issue so much. I mean, if they failed at, okay, well, yeah, but then they probably would have failed something else, long before that point. Simple reaction time is well preserved for a long time. It's really more about the visual field and processing of that information. And with dementia, your visual field of not so much the actual field, but the field that you can actually pay attention to and act on. It becomes more diminished. So it starts out here when you're a young driver, all of us in this room, and it eventually focuses this way until eventually they can only pay attention to what's here and process, and that processing time may be limited, may be elongated and beyond what it should be. So if somebody steps off a curb, they will not process that information. Even though they might, quote, see it, the eyes might be fine, they're not processing it. Doesn't count. Not like horseshoes. Anyone else? All right.
Very good. Thank you very much.
Thank you very much.